account. So, the importance of intraocular pressure. Intraocular pressure is the main risk factor for the development and progression of glaucoma. We all know that, and lowering intraocular pressure decreases the risk of progression, and protective effect of IOP is dose dependent. All stages of glaucoma, starting from ocular hypertension to early and advanced glaucoma, benefit from intraocular pressure lowering. Target IOP, as defined by the American Academy, is the goal of treatment to maintain the IOP within a range at which visual field is unlikely to substantially reduce the patient's health-related quality of life over his lifetime. The estimated upper limit of this range is considered the target pressure. The European Glaucoma Society said the estimate of the mean IOP obtained with treatment that is expected to prevent further glaucomatous damage, an individual dynamic and modifiable parameter. If glaucomatous damage occurs under IOPs that are below the initially determined target, this target needs to be further reduced. So the rationale for target IOP is the only modifiable risk factor that affects the progression of glaucoma. Different individuals respond differently to the same level of IOP and necessity to establish a target IOP for each and every patient. So target IOP depends upon IOP at which damage has occurred, severity of visual field damage, rate of progression of damage, and the age and life expectancy of the patient. Central corneal thickness. So as we all know that the normal cecity is about 520 microns, and underestimation and overestimation occurs. As you see in the graph there, it's about 70 microns change in cecity corresponds to 5 millimeters of IOP difference. So the factors influencing target IOP: severity of disease, the extent of visual field damage, fixation threat. The more severe, the lower the target IOP. You have to consider the life of the patient, life expectancy, and the rate of retinal ganglion cell loss, the physiological loss of retinal ganglion cells with age. Glaucoma accelerates the loss. The variable, slow in most patients but fast in a few, and first progressors must be identified and treated aggressively. As you see in that graph, there's somebody whose progression is like this needs to have a lower target pressure than somebody whose progression is on this line. So the target IOP in ocular hypertension, it's anything between 20 or more percentage that you need reduction. That's about 16 to 20 the range. And in early glaucoma, about 30%, that's 14 to 18 the range. In advanced glaucoma, about 40%, that's about 12 to 16. And where visual field and optic nerve photos indicating progression since therapy, so additional another 15%, which brings down to about 10 to 14%. So factors influencing target IOP is baseline, important to detect the IOP at which the glaucomatous damage occurred. And the lower the baseline IOP, the lower should be the target IOP. So the central corneal thickness, I just told you about it. It is a predictor for glaucoma conversion, as we saw in the oath study. And it's unclear if it is a risk factor per se, basically. So the consequent of CCT on IOP measurement still has not been given very properly. So unclear if it should be considered in determining IOP. Corneal hysteresis, however, is more prone to progression. So the factors which influence intraocular pressure, you can see starting from sex right down to a lot of things that are there which influence intraocular pressure. So it is a difficult thing to set a target IOP actually. As we know, it's your race which makes a difference. African Americans show a higher prevalence of glaucoma than the Caucasians, and associated ocular and systemic disease like pseudoexfoliation, systemic hypertension, antihypertensive medications, these all contribute to the intraocular pressure. And when we do it, we have to weigh the risk benefit of the treatment, the impact of treatment on the quality of life. If you see that IOP actually is such a variable in resistance training, look at the graph. Walking and cycling, meditation and yoga, and alcohol consumption brings down the intraocular pressure. So worst times of the day for your IOP is at night when you're sleeping. And so what we measure in the office is actually the lowest IOP. And then you have to be careful at what gaze you're measuring the IOP, because if you look at that graph by Van Reb et al., you would see that if you're measuring in the upper gaze, that's where the IOP reaches. And you're measuring in the lower gaze, that's where the IOP reaches. So to get the optimum IOP, you've got to ask the patient to look straight. Influence of body position on IOP. Look at the scatter graph out there as well. And the relationship between IOP and risk progression. So these are the different studies. which showed the risk progression 10 to 13, 10%, 12%, and 19% with the hazard ratios. So overall, we take a 10% risk reduction for every 1 millimeter of IOP lowering. So we know that the variable IOP can actually go from 5 millimeters of mercury to 12 millimeters of mercury, depending on the visit and the time that you're taking the IOP. And as we know, the nocturnal IOP is always higher. I just told you about it, than the diurnal IOPs, which we take at the office. So IOP, if you take it as a global risk factor, it has about 63% percentage of patients who progress actually if the IOP is more than 22 millimeters of mercury. And making sense of IOP fluctuations is a very interesting thing, because IOP behavior at specific times on a given day does not provide a meaningful information regarding IOP at specific times on other days. And if you see that graph, the peaks of these three graphs actually are the troughs of these three graphs, taken, say, about 7,756 individual intraocular pressures for about 77 seconds. So these are various papers which actually talked about it. There's a seasonal variation at all, shown by Venreb et al. And the routine continual IOP monitoring improves management, enables sustained release treatments, improves adherence to medications, and a plethora of data we get from there. So this is an IMate which is on the process, which will take a continuous IOP reading so that we can arrive at better conclusions. So the challenges are long-term safety, reducing the size, big data interpretation, and of course, the money involved in it. So our thoughts and emotions actually influence our intraocular pressure. A small word about nocturnal hypotension. So patients who progress even with well-controlled pressures within the target range with the 24-hour blood pressure monitoring frequently have nocturnal hypotension. So low blood pressure coupled with high IOP in supine position compromises perfusion pressure. So it's better to use your medications taking into account this nocturnal hypotension, as beta blockers do not work very well at night. And of course, the blood pressure. So this is a little bit about the drugs, which Dr. Partha has also told you, and I've just told you as well. So in conclusion, I'd like to say that stage disease within the glaucoma continuum, assess all the risk factors, use risk factors to estimate global risk, weigh variables that impact treatment, establish treatment goals, and target therapy to appropriate the patient risk level.